Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. We have more than 300 cardiology seminars on our YouTube channel, ranging from basic cardiology science all the way up to 2022 ACC/AHA guidelines. We would like you to watch those videos and do share them with your friends. Please do subscribe to our YouTube channel, and at the end of the presentation I'm going to tell you as how you can get a copy of my cardiology rotations manual, a very useful manual for those seeing patients in the hospital or in the clinic, which has all this pertinent information that is needed for clinical practice. So I'll tell you how you can get a copy of this at the end of this presentation. I also have an EKG book interpretation, which is on Amazon.com, but you don't have to necessarily buy the book. All the chapters in the book have been put together in a video format on our YouTube channel from chapter 1 to chapter 14, and you can watch those on our YouTube channel. Okay, let us begin with the feature presentation. The feature presentation is Cardiology Board EKG Interpretations, Metabolic Changes, and Congenital Conditions or Heart Diseases. This is based on the concept of how a cardiology fellow is tested in the cardiology boards, and those who are preparing for the board exams will see this template, the answer key. After interpreting the electrocardiogram, the boxes they have to check. So why not learn the way the cardiologists interpret the electrocardiograms? And this is what the purpose of this presentation is. I have several presentations for each one of these segments, and there's an overall presentation covering this entire answer key sheet. Please do watch them. And we have already covered general features, rhythm disturbances, atrioventricular conduction delays, axis on voltage. In this presentation, we're going to be focusing on clinical disorders, that is metabolic disorders affecting the electrocardiogram, or the electrocardiogram reflecting the metabolic disorders, and some congenital conditions that can give abnormal electrocardiograms. And in the future presentations, we'll be talking about the intraventricular conduction delays and myocardial ischemia and infarction, which is going to be a major topic for your cardiology board exams, or for example, even if you're looking at an electrocardiogram in the emergency room, in the ambulance, or in your primary care office. Of course, pacemaker functions will be of great importance to know what the pacemaker is doing or not doing based upon what it is supposed to be doing. Okay, let us focus in this presentation on the clinical disorders. So let us begin with the feature presentation. I just expanded some of the conditions that have been covered under this clinical disorders, including Brugada syndrome, Digitalis toxicity, torsade, hyperkalemia, hypocalemia, hypercalcemia, Dextrocardia, carpulmonale, pericardial effusion, acute pericarditis, Hypertrophic Cardiomyopathy, central nervous system disorders, and hypothermia. A whole mouthful of terminologies, but you may not be getting every one of these. You may just get one or two of these, or maybe three of these, but it is important to understand the significance of the metabolic changes in the electrocardiograms. In order to understand the metabolic changes that can affect the electrocardiogram, first of all, we need to get back to the basic science, and that is the action potential. As you know, the myocardium has a resting membrane potential of minus 90 millivolts, and with the influx of the sodium ions into the cells, we get the phase 0 of the action potential, which represents your QRS complex. Then we have the slow phase where it is sustained positive membrane potential by the removal of the potassium from the cells and influx of calcium. And since these are involved in the ST and T wave segments of the electrocardiogram, the changes that affect the EKG by changes in potassium and calcium will be predominantly dependent upon will be shown in the electrocardiograms in the STT segments and also the QT interval. So let's keep that in mind. And this is the myocardial cell or the myofibril, the individual cells. Then here we have the interstitial space where this exchange of ions that happen during each cardiac depolarization. And this is a resting membrane potential again. So let's keep this in mind so it helps us to understand better as why we see certain changes. So let us look at this electrocardiogram and see what is your diagnosis and why you say that is the diagnosis. Well, obviously, if you look at this electrocardiogram, there are quite a number of things that are pretty obvious. You have tall peaked P waves measuring 20 millimeters. Tall, narrow, peaked T waves. These are different T waves from the tombstone T waves we see with big anterolateral myocardial infarction. So we have to differentiate these points because these are tall, peaked, narrow T waves, and this is suggestive of hyperkalemia or high potassium level, like in patients with renal failure who come in with weakness, lethargy, and you see the creatinine is up, and more importantly, the potassium is like 7.4 or maybe 8.0. And when you look at this electrocardiogram, that should tip you off that you're dealing with hyperkalemia, which is a medical emergency because these patients need to be dialyzed to bring the potassium level down. If not, it can further deteriorate into a more serious rhythm problem. So always keep in mind, whenever you see tall peaked P waves, there may be a word or two in the history that might give you a suggestion. A renal patient presents with weakness and lethargy or fatigue. That should be a tip-off right there. And in addition to that, we also have sort of flat T waves here, and you can see the T waves are taller than the R waves and some non-specific T wave changes. Let's move on here, and we are going to look at the effect of a potassium level and the EKG changes associated with them. Let's start off with hyperkalemia first. When the potassium level goes beyond 6.5, we see tall peaked P waves, and then when it gets to 7 and 8, we begin to see these sine waves with the drop of the J point and a upward sagging ST segment with a T wave. And when the potassium reaches 8 or 9, we have the loss of P wave amplitude, loss of R wave amplitude, followed by a slurred S wave and a ST segment and a T wave producing a sine wave. So this is a very grave situation. And if you see something like this, I think you need to call the nephrologist, and they need to fix the electrolyte imbalance. On the other hand, if you look at hypokalemia, which is also a major problem that we see in patients, especially cardiac patients who are on diuretics, who are also on several things that can alter their potassium level, or if they're having diarrhea, or if they are having some colon problems. So when the potassium level gets to 2.8, then we begin to see some flattening of the T waves and prominent U waves. What happens sometimes is that the T waves and the P waves blend together, producing what looks like a pseudo QT interval prolongation. And as the potassium level goes lower and lower, we begin to see the downward slagging of the ST segment with a sort of a flat, rounded T waves, or more or less the T wave blends into the P wave, giving a false prolonged QT interval. So these are some of the features you really need to pay attention to when you are looking at an electrocardiogram. As I said, there could be a word or two that might tip you as to what to look for, and make you just confirm that by looking at the electrocardiogram. This is hypokalemia, and this is hyperkalemia. Hyperkalemia, tall, peaked P waves, narrow T waves, and then sine wave. Hypokalemia, flat T waves, U waves, prolonged QT interval, which is spurious prolonged QT interval, and then sagging ST segment. Here is a little table that is kind of summarizing what I have said. If the potassium level is 5.5 to 6.5, we see peaked T waves, repolarization abnormalities, and then we get a prolonged PR interval, widening of the P wave. If the potassium level is 6.5 to 7.0, then we have drop P waves, and when it gets, you get a wide QRS complex, the sine wave which I just showed to you. All right, here is an example of tall peaked P waves. Also, there is right bundle branch block with slurred S waves. So whenever we see tall peaked P waves, we should consider there's also flattening of the P waves, as we can see here, and this right bundle branch block, of course, here. And this is another example of hyperkalemia. Let's move on to the next one here. And this is a case of an advanced hyperkalemia patient, which beginning to show the so-called sine wave, as we can see here. This widening of the QRS complex, these P waves have almost disappeared. Then we have the upsloping ST segment blending with the flattened T waves. There may be a PU wave, but maybe we don't see it. But this is an extreme case of significant hyperkalemia. As I said, upsloping ST segment, peak to T waves, sine waves, reduced R wave amplitude, and loss of P waves. Okay, hypokalemia EKG changes. I just want to kind of summarize, which is in this book actually, increased height and width of the P waves. Actually, the P waves look kind of peaked in the limb leads. There is PR prolongation. Everything becomes sluggish with hypokalemia. And this flattened inverted T waves, ST depression, prominent U waves, which is a very important feature. And I talked about the combination of T and U waves giving what looks like a prolonged QT interval. Of course, when you have low potassium, patients are prone to have PACs, PVCs, atrial flutter or fibrillation, and even ventricular tachycardia or arrhythmias. And here is another example of an expanded version of what are the things that you can see in patients with hypokalemia. There is sort of a peaked T waves, then we have prolonged PR interval, there is a sagging ST segment depression, shallow T waves, and a prominent U wave. So the prominent bump that we see may be most of it U wave, whereas your T wave may be just like a hump on the upslope of before the upslope of the prominent U waves. So these are some of the salient features of hypokalemia when you look under the microscope. All right, let's look at here, and here's an example of what I was talking to you. There's sort of a peak to P wave here, but more importantly, there's the J-point depression, upsloping ST segment, and there is a T wave, and this is probably a U wave, which is giving a false prolongation of the QT interval. And all of these put together, you should be thinking about hypokalemia. And there may be a point in the history that might help you to pinpoint the diagnosis. Digitalis toxicity. Digitalis is not very commonly used these days. The only couple of conditions that I have used digitalis is in acute decompensated heart failure, especially if they have associated atrial fibrillation with rapid ventricular response. And in those patients who have atrial fibrillation with rapid ventricular response, who have been on maximum doses of beta blockers or calcium channel blockers, and you're looking for an alternate drug to increase the AV blockade, that's when you use digoxin on a short-term basis. But in the days when digoxin was used on a routine basis for patients with heart failure, we used to see all kinds of arrhythmias, but you need to memorize these changes that are related to digitalis toxicity, because I'm pretty sure whether you have used digitalis or not, they may question you on the EKG changes associated with the digitalis toxicity. As a matter of fact, digitalis toxicity can mimic any kind of arrhythmias. It can produce PACs, PVCs, atrial fibrillation, ventricular premature beats, VTAC, and STT changes. So let's look at some of the salient features of STT changes that are unique to digitalis toxicity, namely short QT interval. This J point depression. The J point is supposed to be at the baseline. We see J point depression. Then we have the sagging downsloping ST segment. After that, we have sort of a biphasic T wave, and there is a U wave. So these are some of the important features of digitalis toxicity. And here's an example of a sinus rhythm, and this J point depression, this sagging ST segment and T wave inversion, and a biphasic T wave, and probably, so this could be evidence of digitalis toxicity, and it's usually confirmed by the serum digoxin level. Basically, you just have to reduce the dose or stop it altogether to get rid of, more importantly, arrhythmias related to digitalis toxicity, which may be more harmful than giving any benefit. Along with that, we also have in this tracing like maybe a 2-to-1 block, which is also a feature of digitalis toxicity, especially if you see a PAT with 2-to-1 block. It is supposed to be almost diagnostic of digitalis toxicity. So this is, as you can see, there's a P wave, it's a P wave. So we could be dealing with a 2-to-1 block, and with these STT changes, this is a strong indication for digitalis toxicity. Again, we're going to come back to the action potential when we want to talk about calcium, hypocalcemia, where the serum calcium level is less than 8.5 milligram per deciliter, whereas hypercalcemia is defined as greater than 10.5 milligram per deciliter. Calcium influx into the cells causes shortening of the ST segment, shortening of the QT interval, whereas reduced calcium in the interstitial space leads to prolonged ST segment and prolonged QT interval, and these patients are prone for developing torsade. So whenever you see calcium abnormalities, we always need to be concerned about ventricular arrhythmias, STT changes, QT intervals, and potential for VTAC or torsade. Let's look at some examples. Here's an EKG from a patient with hypercalcemia. Some of the important features of hypercalcemia is a shortened QT interval, and this what looks like an Osborne wave, whereas the ST segment is elevated with a rounded top with an inverted T wave, which is also seen perhaps in patients with hypothermia, which I have an example of that. So whenever we see something like this with a short QT interval, we should be thinking of hypercalcemia, high calcemia level. And in addition to that, we also have a right bundle branch block, right axis deviation, anterior infarct here because of the QS in 1 and ABL. All right, let's move on to the next one here. Here's an EKG from a patient with hypocalcemia. Hypo means low calcium level. When you see low calcium level, then the things that we're going to see are the prolonged QT interval, flattened T waves, and a long ST segment. Look at the ST segment here, the ST segment here, and compare that to the ST segment here. This ST segment is barely perceptible. It looks like it just from J point, almost the T wave is beginning to form. Whereas here we have a prolonged, where is my mouse arrow? We have prolonged ST segment. So you need to remember these things. And again, history is an important aspect when we are dealing with these subtle changes. And here is an example of a patient with, can you take a guess? Of course, we see like a double hump here, and maybe some prolonged PR interval, first degree AV block. Whenever we see a double P wave, we need to think about cardiac transplant. In addition to that, we also have low voltage, we also have right bundle branch block, we have non-specific T wave changes, and of course low voltage in the lateral leads, not necessarily the anterior leads. So this is an EKG from a patient with cardiac transplant. Of course, it's not on this list here. This is like a bonus electrocardiogram. But as a cardiologist, sometime in your practice, you're going to come across a cardiac transplant patient whom you may be following in your office. And when you do an EKG, remember, you can see two atrial activity because part of the patient's original left atrial wall is left along with the atrial wall from the donor, which is attached to that. Okay, now let's talk about hypothermia. Hypothermia produces a lot of different EKG changes. It is characterized by a notch on the QRS complex. As you can see, we see the ST segment, J point is elevated, the ST segment. Then we have downsloping, J point is elevated, downsloping rounded J point, downsloping ST segment, and an inverted T wave, which is known as the Osborne waves. The P waves can be flat. There is low voltage, and there is prolongation of the PR, QRS, and QT intervals. It slows down the entire metabolism. Remember, when you put something in the freezer, everything slows down. We have bradycardia, junctional bradycardia, atrial fibrillation, high-grade AV block, muscle tremors, ectopic beats. So these are all some of the findings that we need to keep in mind when you look at an electrocardiogram. And if there is a word in the history that suggests something that might relate to hypothermia, had made a trip to Alaska or some ski resort, that may be a tip off. Okay, and here is an example of a patient with hypocalemia. As we can see, there is flattening of the T waves. There is prominent U waves, which is causing a prolongation of the QT interval, and the QRS looks okay. Can you take a guess as what this represents? Well, we have a negative complex in lead 1, a positive complex in AVR. Is this a lead misplacement? We need to still look further. Oh, there's negative complex all the way across the chest leads, and they get worse as you move towards the right side, left side. As you move towards the left ventricular side, there's an incomplete right bundle branch block. What could this be? And this is a young person. Well, if you look at the chest x-ray, well, maybe they put the chest x-ray wrong. The heart is on the right side of the chest. Well, maybe the EKG is the same thing. Maybe it's wrong. It's on the right side. No, actually, this is a case of a Dextrocardia. So everything is going to be on the right side. How do we confirm that this is not lead misplacement? Very simple. You just do, instead of putting V1 to V6 on the left side, put V1 on the left side, V2 on the right side, and put all the leads on the right side, V6 up to V6, and you get positive deflections. When you get all those positive deflections, that means you are dealing with dextrocardia. And you need to know this one because the dextrocardia is here listed somewhere. Yeah, dextrocardia, mirror image. So this is a mirror image of what a normal electrocardiogram should be. And this chest x-ray sort of confirms that. So if you are suspicious, or if you do the auscultation and you hear the heartbeats on the right side of the chest, That could also be a tip-off, but just try to put the leads on the right side of the chest like you would normally do on the left side, and that might confirm your diagnosis. All right, what do we have here? Oh gosh, this evidence of significant ST elevation in multiple leads, lead 1, ABL, 2, 3, ABF, V1, 2, V6, along with more or less sinus tachycardia. So, what is this? What are the differential diagnoses? Is this an acute myocardial infarction? You can't be having global myocardial infarction. Myocardial infarctions are usually related to a regional artery which is occluded, either anterior descending artery, the circumflex branches, or the right coronary artery. But this is diffuse ST elevation, especially if it's a 28-year-old man who comes with some fever, some aches, and then you're talking about pericarditis. When we are talking about pericarditis, we need to pay attention to not only the ST segment and elevation of the T waves, but also the PR segment. And here is a classic example of PR depression, because there are conditions where we may see some generalized ST elevation. If a 40-year-old hypertensive young man comes in and all of a sudden you see 2 millimeter ST elevation in multiple leads, and they say, oh man, you got a problem, you got pericarditis, I need to send you to the emergency room. No, you don't do that. So we need to know what we are dealing is normal variation, or is this abnormal? This is abnormal. Somebody with a fever, little aches and pains. Now, diffuse ST elevation, a young person, you think about pericarditis. And here's an example of what I was talking to you earlier. A 40-year-old person with hypertension who comes here and you do this electrocardiogram and say, oh, should I call the ambulance? I see ST elevation here. Oh my God, 1 millimeter ST elevation, more than 2 leads. Oh, here inferior leads, ST elevation, anterior lateral leads, chest elevation, 911. No, hold on. Don't call 911. This is a normal variation. It's called the early repolarization, which is commonly seen in young people, especially African American males, without any history, or they may have some mild hypertension. When we see this, we need to be concerned about. There's another point here which is kind of drawing my attention, and that is inverted P waves in lead 2, 3, and AVF. Whenever you see an inverted P waves, you think about ectopic atrial beat rhythm. And that's an important extra point, but it is to be mentioned because this is not sinus rhythm. It is atrial rhythm, because we have an inverted P wave in the inferior leads. Okay, let's talk about in patients with hypertrophic cardiomyopathy. There are certain important features that we see which may suggest as to the nature of hypertrophic cardiomyopathy we are dealing with. In addition to having increased voltage, left atrial abnormality, and left axis deviation if it is present, if we see these deeply narrowly inverted T waves in leads, anterior and lateral leads, you think about hypertrophic cardiomyopathy, especially the apical type of the hypertrophic cardiomyopathy. We always have to consider, because in just regular hypertrophy, the T waves are much wider or smoother, and we see, of course, the downsloping ST segment. We see all those things, but these T waves are pretty narrow and deeply inverted T waves. And when we see this, keep in mind you're dealing with hypertrophic cardiomyopathy. And the worst possible T wave changes that you can see in your whole practice is this giant negative T waves, huge jumbo T waves. And when you see this, it should just light up your bulb in your brain, and that is, you may be dealing with a patient with a cerebrovascular accident with increased intracranial pressure. That's one of the conditions where we see this, and that's an important point to remember. So, ladies and gentlemen, this is a very quick synopsis of the EKG changes that we see with metabolic abnormalities and in patients with congenital heart disease. I told you how you can get a copy of this book. Simply send me an email to drniknikam at gmail.com, and I'll be happy to send you a PDF copy of this book. And please do subscribe to our YouTube channel. I will see you in the next presentation. I am Dr. Nik Nikam. This has been a Triple N Media EKG Board EKG Interpretation segment. Thank you so much, and please do subscribe to our YouTube channel.